Can COVID is an open science collective dedicated to rapidly mobilizing and sharing knowledge to help inform Canada's COVID-19 response. To learn more about us or how to join our community, you can visit our website at cancovid.ca.
Great.
All right, I'll start admitting people in about 10 seconds.
Thanks, Harris. Welcome to everyone that's joining us now. We're just going to take a few minutes to allow us a bit of time for people to join us, and then we'll get started right away. It's just 12 o'clock now, so we'll give people 1 minute. There we go. I think we'll get started now. Welcome, everyone. This is a special event on COVID-19 in Canada, Disparities, Compliance with Preventive Measures, and Mental Health. I'm Susan Law, Managing Director and Knowledge Mobilization Lead at CanCOVID, and I have the pleasure of being today's moderator. Our team at CanCOVID was asked to partner on today's event with a group from the University of Ottawa. And I'm so pleased that we could do this with them together. And I think you'll find their work extremely useful and relevant to today's issues related to COVID-19. Now, before I introduce our first speaker, I'd like to encourage our attendees to submit their questions into the chat area at the bottom of your screen, and I'll direct as many of them as possible to the speakers at the end of the presentation during the Q&A session at the end. So without further ado, it's my pleasure to introduce today's first speaker, Dr. Roland Pongou, Associate Professor of Economics at the University of Ottawa. He'll be providing us with an overview of all of this team's work. Roland, welcome.
Thank you, Susan, for the introduction. We would like to thank Q and the COVID-19 and the CanCOVID team for inviting us to give this presentation. We would also like to thank each person in the audience for attending. As we all know, the COVID-19 pandemic has had profound social, economic, and psychological impacts on individuals of all ages. Canada reported its first case of COVID-19 on January 25th, 2020, only 5 days before the World Health Organization declared COVID-19 a public health emergency of international concern, and approximately 2 months before it was declared a global pandemic. Since the beginning of the pandemic, Canada has recorded over 1.7 million cases and over 29,000 deaths. You know, you might think this is a lot, but I should say that Canada has been quite successful in terms of preventing the spread of COVID-19, especially when compared to other rich countries around the world. This map shows how Canada is doing relative to other countries around the world. We calculated that the cumulated number of cases per capita today is approximately 1.4 times greater for Canada than for the whole world. Okay, next slide, please. However, when Canada is compared to other rich countries, this figure shows that Canada has been quite successful in terms of preventing the spread of COVID-19. Out of the 37 or 38 OECD countries, Canada ranks 29th in terms of the prevalence of reported positive cases per a million of population. So Canada is doing quite well. Next slide, please. Canada is also doing well relative to other countries in terms of averting death from COVID-19. These figures have just shown you might leave us with the impression that Canada has been quite successful at preventing COVID-19 and its consequences in all population segments. In this presentation, we want to show you that this is not actually the case. There are significant disparities in several important COVID-19 related outcomes. Next slide, please. Our goal in this presentation is twofold. First, we examine social demographic disparities in COVID-19 symptoms, testing behavior and compliance with preventative measures in Canada. And the second goal of our presentation is to examine the distribution and predictors of poor mental health during the COVID-19 pandemic. Next slide, please. This is the roadmap of the rest of the presentation. Christelle will present the materials and methods used for our analysis and will present our first paper on the social, economic, and demographic disparities in COVID-19 symptoms in Canada. Following Christelle's presentation, Bright will present the next two papers on the social, economic, and demographic disparities in COVID-19 testing and social distancing behavior in Canada. Then Arunika will present our fourth paper on the social, economic, and demographic disparities in mental health issues during the COVID-19 pandemic in Canada. And then we'll conclude and acknowledge our partners. Thank you.
Great. Thank you, Dr. Pongou, for providing that overview and for setting the stage for today's session. I'll now introduce our next speaker, Dr. Christelle Mabeu, who's a postdoctoral fellow at Stanford University. She'll begin by covering the materials and methods and then present on the socioeconomic and demographic disparities in the COVID-19 symptoms. The mic is yours, Dr. Mabeu.
Thank you very much, Suzanne, for the introduction. And thank you for inviting us to this presentation. So as Roland mentioned, I will now start by presenting the survey design. Next slide, please. So basically, to help understand the social and economic predictors of the spread of COVID-19, we need individual level data or near real-time data on the pandemic. But with the lack of population-based data with relevant information to study these predictors of the spread of COVID-19, we conducted an online survey in order to collect this socio-demographic information and information related to COVID-19 symptoms. We also tried to collect information on COVID-19 testing and compliance with mitigation measure at the individual level. So the web survey that we conducted was mainly through Facebook. We know we have seen a growing number of studies in social science that have used social networks to recruit web survey participation, especially in these high-income countries like Canada, where in Canada, the social network penetration rate is quite large. It's more than 80% of the population who has access to or who has a social network account. So web surveys have clearly a lot of advantage. They are less expensive than traditional probabilistic sampling techniques. But with online surveys, we can also have the possibility to reach those very difficult population groups or rare or hard to reach population groups. However, one important limitation that we should mention regarding social network surveys that these surveys are generally not representative of the population. So basically, by running Facebook survey, we'll probably end up with a sample that is only representative of the population with a Facebook account. So to improve representativeness of our online survey, we'll we weight our sample in order to adjust the sample distribution to meet the Canadian Census survey. But before I show you some statistics that will that will show how we actually adjusted our sample, let me now give you a few more details on our Facebook campaign. Please, next slide. So the campaign was conducted and monitored by the communication team of the University of Ottawa. So the campaign was largely advertised via the Ottawa Facebook account, but each authors on this paper also independently share the advertisement through its personal social network accounts. So in practice, what happened is that the picture here, which shows the caption of the campaign, was advertised. So we targeted both Anglophone and Francophone residents of Canada aged at least 18 years old. And each Facebook user reached by the campaign will see this caption with a short text informing the users about the survey and encouraging them to take part in it. So we run, next slide, please. So we run 3 runs of the survey. Basically, we have a longitudinal surveys, but during the presentation, we'll only focus on the first wave, which was conducted between July and October 2020. So prior to the peak month of the second COVID-19 wave, as you can see on this graph. In overall, a total of about 5,000 people completed the survey. But you will see during the presentation that the sample that we use in the analysis will vary a bit. That will be depending on the number of people that has information on all the variable of interest. So next slide, please. So here, this table shows some demographic statistics. The second column here shows the sample mean of the survey. The third column is actually the sample mean adjusted or weighted. So when we try to adjust that by using the census data, which is shown in the national estimate in the last column. So overall, as expected, the survey is not representative of the national population. We can see that there is an overrepresentation of female groups, age groups or groups aged at least 65 years old. And we also have an overrepresentation of residents of Quebec. So survey respondents were also less representative of Canada in terms of population age less than 65 and province other than Quebec. So we weighted the sample to meet the 2020 Canadian census data. As you can see in the last 2 columns, the mean now are the same with the national estimate. And we therefore apply the weight through the analysis that we'll present in the next slide. Please, next slide. So now I will show you the result for the first analysis, which seeks to understand the distribution and predictors of Canadian reporting possible COVID-19 symptoms. Next slide, please. So we'll try to understand, as I mentioned, the distribution and predictors of Canadians reporting possible COVID-19 symptoms, but we also try to understand whether these predictors differ by gender. So in the survey, each respondent were asked whether they had experienced any of the symptoms suggestive of COVID infection. So these symptoms include fever, dry cough, shortness of breath, and decreased sense of smell or taste. We define our outcome, the outcome named self-reported symptoms, as equal to 1 if the respondent reported one of the COVID-19 symptoms that I mentioned. And when we do a simple weighted tabulation, we find that about 30% of the samples self-reported having COVID-19 symptoms, with more men than women who self-report symptoms suggestive of infection. Next slide, please. So to understand how these socio-demographic factors are associated with COVID-19, self-reporting COVID-19 symptoms, we conducted a logistic regression analysis where the outcome was the self-reported symptom variable that I mentioned. And we'll do the same kind of logistic regression analysis through the paper when my colleague will present the other papers. So in the logistic regression analysis, basically what we did is just to use the explanatory variable, which are gender, age, province of residence, ethnicity, race, and education, income, and number of household members. In this graph here, we report the odds ratio, which is simply the degree of association between the exposure variable and our main outcome of interest. The graph on the left shows the odds ratios from separate bivariate analysis, meaning that each point here represents a separate regression analysis where we use each exposure variable individually. And the graph on the right shows the odds ratios from the multivariate analysis where exposure variables are analyzed simultaneously. Overall, what we find is that people above 45 years old and people from higher income group, those residents of British Columbia, and to some extent, people living in large households are less likely to report COVID-19 symptoms. We also see that, and that's striking, Black and mixed race are associated with higher odds of reporting symptoms. So when we do, next slide please, when we do the stratification or the analysis by gender, we also find very interesting results. So we see that Black women and men have higher odds of reporting COVID-19 symptoms, but the effect is more pronounced for Black women. And we can also see that men from mixed race are more likely to report symptoms, while this is not the case for women from mixed race, meaning that the result that I showed previously, it seems to be mainly driven by this, by men, by this group of persons for the mixed race. We also observe that residents of British Columbia are less likely to report COVID-19 symptoms. This is relative to residents of Quebec's province. But this result is only true for men in British Columbia, but not for women. So we implemented similar analysis for the other COVID outcomes, including testing behavior. And I will let now my colleague Bright present these results. Thank you so much for your attention.
Thank you, Dr. Mabeu, for describing these methods and materials and for covering the disparities aspect. That's wonderful. So now I'd like to turn to our next speaker, Bright Opoku Ahinkorah, a PhD candidate and research assistant at the School of Public Health at the University of Technology, Sydney, Australia, and associate editor at BMC Women's Health and BMC Public Health. Bright will begin by presenting the socioeconomic and demographic disparities in testing behavior, followed by the socioeconomic and demographic disparities in compliance with mitigation measures. So Bright, over to you.
Thank you very much, Suzanne, for the introduction. So like Suzanne said, I'm going to present two papers. The first one will focus on the socioeconomic and demographic disparities in testing behavior, and the other one will look at socioeconomic and demographic disparities in mitigation measures. So in terms of the testing behavior, please next slide. In terms of the testing behavior, we derived the outcome variable from a question, have we ever tested for COVID-19? And the responses were yes and no. And as we can see from the descriptive results, we found that 18% of the respondents reported testing for COVID-19. However, there was a disparity by gender where we found that more women were tested for COVID-19 compared to men. So 21% against 15%. Next slide, please. So as my colleague Christelle already mentioned, we further did the results or analyzed the data looking at using logistic regression. And then we looked at both bivariate and the multivariate. And from the multivariate results where all the independent or explanative variables were included in the model with the outcome, we found that male respondents were less likely to test for COVID-19 compared to females. And those who were aged 65 and above were also less likely to test for COVID-19 compared to those who are 18 to 44. Living in British Columbia reduced respondents' likelihood of testing for COVID-19 compared to living in Quebec. However, respondents who lived in Alberta were more likely to test for COVID-19 compared to those who lived in Quebec. Having a college or postgraduate education also enhanced the likelihood of testing for COVID-19. And respondents who experienced symptoms of COVID-19 were more likely to test for COVID compared to those who had no symptoms. These results further show disaggregation. Next slide, please. When we looked at them among males and females separately, and the results showed that province was only the significant factor associated with testing for COVID-19 for males. However, for females, we found that age, province, education, and experiencing COVID-19 symptoms show significant associations for testing among females. The next paper, which I'm going to present, next slide, will look at socioeconomic and demographic disparities in compliance with COVID-19 mitigation measures. So with this slide, we will also look at the variations across gender. Next slide. So the workplace is an environment that enables and exacerbates the spread of COVID-19. Like all other diseases, the spread is through respiratory droplets. So there is the need for us to get a level of proximity for people, and then hence the need for social distancing. So the first aspect of the mitigation measures is the social distancing, which we have defined as the number of persons who came in close contact with a person within 6 feet, with the respondent during the last day that the person was at work. And our results showed that close to 50% of the respondents indicated that there were less than 10 close contacts at their workplaces. This varied by gender with a higher prevalence among males compared to females. Next slide. So the odds of mitigation, compliance with mitigation measures was lower among Black Canadians compared to white Canadians. Next slide, please. And when the results were disaggregated by gender, ethnicity showed significant association among males, while respondents of the mixed race were less likely to comply with mitigation measures compared to white Canadians. For females, age, ethnicity, and education showed statistical significance. Specifically, among the female respondents, those who are aged 65 years and above were less likely to comply with mitigation measures compared to those 18 years and 18 to 44. And Black female Canadians were less likely to comply with mitigation measures. And the mitigation measures here, as I mentioned earlier, is the one on social distancing. Then in terms of education, those with postgraduate education were less likely to comply with mitigation measures at the workplace compared to those with high or less education. Next slide. So as part of the mitigation measures, we also looked at the distribution of personal preventive measures at the workplace. And the personal preventive measures includes wearing of face mask and disinfecting workstations at the workplace. We also looked at wearing of masks in public. So I'm going to look at both personal preventive measures at the workplace and the wearing of face mask at the public place. So in terms of the descriptive results, as we can see, more than 90% of the respondents mentioned that they practice personal preventive measures at the workplace, and this varied by gender. And as we have seen, 96% females versus 87% males were practicing personal preventive measures at the workplace. In terms of wearing of face mask in the public, close to 60% of the respondents indicated that they did that, and this also varied by gender, with more females compared to males wearing face masks in public. Now, in terms of the factors that were associated with personal preventive measures at the workplace, there were significant associations. Please, next slide. There were significant associations in terms of gender, province, visible minority, and education. And the specific results from the multivariate level showed that males were less likely to practice personal preventive measures at workplace compared to females. Respondents in Ontario and other provinces were also less likely to practice personal preventive measures at the workplace compared to those in Quebec. We can also see that respondents who identified as visible minority were less likely to practice personal preventive measures at workplace compared to those who did not identify as visible minority. And respondents with postgraduate education were more likely to practice personal preventive measures at workplace compared with those with high school or less education. Most of these factors, as we can see from the next slide, please. Most of these factors showed significant association with personal preventive measures at the workplace for males and females separately. So as we can see, even though these factors show significant associations at the level where we included males and females, now when the results were disaggregated by gender, we found that there were variations in terms of the factors that were predicting this particular outcome variable for males and females separately. Next slide. Now, face covering at public was also one of the mitigation measures we looked at, and the results showed that gender, province, and visible minority have significantly associated with face covering in public. As shown in the figure, male respondents and respondents who identified as visible minority were less likely to wear face masks in public compared to female respondents, and those who did not identify as visible minority, respectively. Please, next slide. And finally, when the results were disaggregated by gender, province was found as a significant factor associated with the wearing of face masks in public for both males and the females, but visible minority was significant for males, but not for females. Thank you so much.
You're right. That was a terrific overview. So we'll now turn over the mic to our final presenter, Arunika Agarwal, Research Associate at the T.H. Chan School of Public Health at Harvard University. She will begin by covering the socioeconomic and demographic disparities in mental health, followed by the team's concluding remarks. So over to you, Arunika.
Good day, everyone. And thank you, Suzanne, for the introduction. So as Suzanne mentioned, I'll be talking about the distribution and disparities of mental health issues during COVID-19 in Canada. Next slide, please. So to assess mental health of the respondents, we used internationally validated tool called Patient Health Questionnaire 4, also called as PHQ-4. And as the name suggests, PHQ-4 has 4 questions assessing anxiety, depression, and overall psychological distress of the individuals. We should note here that this tool does not diagnose mental health problems, but only suggests that the respondent is possibly suffering from anxiety or depression or psychological distress. The responses are coded from 0 to 3 on a scale of, on a 4-point Likert scale. Next slide, please. And the total scores for all 4 questions are rated as normal if the scores are between 0 and 2, as mild if the scores are between 3 and 5, moderate if they are between 6 and 8, and as severe psychological depressed if the scores are between 9 and 12. The first 2 questions of PHQ-4 actually assesses the level of anxiety, and the last 2 questions assesses depression. And a score of 3 or more for the set of 2 questions for each of these 2 categories suggests that the person is possibly suffering from anxiety or depression. Next slide, please. So this chart shows distribution of anxiety and depression, anxiety by green bars and depression by blue bars across age and gender. Overall, our survey suggests around 25% respondents are suffering from anxiety and 22% are suffering from depression. These numbers are quite higher than the pre-pandemic times, and per 2019 Canadian Community Health Survey, the prevalence of mood and anxiety disorder among 18 to 34 age group was around 17%. So it is evident that the pandemic has aggravated the mental health issues across all age groups in Canada. But as you look deeper, this chart shows that the youngest age group, that is 18 to 44 years, has been worst affected during the pandemic, with around 39 and 35% respondents possibly suffering from anxiety and depression. And this is almost double the prevalence we have found in 45 to 64 age group, and almost 3 times that in the 65 to 84 age group. Though these findings are consistent with the pre-pandemic prevalence of mental health problems in Canada, where the prevalence of these issues, especially mood and anxiety disorders, has been higher among younger age groups. The difference in mental health problem is also striking between males and females, with females suffering from anxiety, more from anxiety than males. And interestingly, the depression was found to be higher among males than females. Next slide. And this chart shows the distribution of level of psychological distress. That is, we take into account all the 4 questions we ask in PHQ-4. And overall, almost half, that's 49% of the respondents, reported some level of psychological distress, with 23% reported to having either moderate or severe distress during the times when the number of cases were rising for the second time in Canada, which was just the starting of the second wave. Next slide, please. Next, we will go over some of the determinants of psychological distress during COVID-19 pandemic. And as discussed earlier by my colleagues as well, the odds of experiencing distress were higher among female and among younger age groups. And these differences were statistically significant. Similarly, lower income groups had higher odds of reporting distress than those in higher income groups, even after controlling for other socioeconomic and demographic variables. And as expected, those with COVID-19 symptoms had a higher odds of being in distress than those who did not experience any symptoms. Next slide, please. We also looked at the determinants disaggregated by gender, and the province of resident came out to be a significant factor for predicting distress, especially among females. With females residing in British Columbia, Alberta, and Ontario and other provinces experiencing higher odds of distress than those residing in Quebec. Among males, income came out to be a statistically significant factor of predicting distress. And it turned out it's the males who were driving the overall association of income and mental health issues in the population, and which was not the case as depicted in this chart among females. Other factors such as experiencing COVID symptoms and age were also significant predictors for both males and females of mental health issues. Next slide. So this brings us to the conclusion of our presentation, and I would just summarize our findings in quick 4 points. So the first, COVID-19 self-reported symptoms were found higher among 18 to 44 age group, among people of mixed race, and among lower income groups. Second, COVID-19 testing was found to be higher among females, among Blacks, those who are highly educated, and among those who reported COVID-19 symptoms. Third, the social distancing behavior was more common among females, those belonging to large household sizes, but was less common among visible minorities and higher income groups. And fourth, anxiety, depression, and overall psychological distress were higher among females, 18 to 44 age group, lower income groups, and those who experienced any COVID-19 related symptoms. So clearly there are certain groups of population, mostly underrepresented, who are more vulnerable than others to having negative impact of the COVID-19 pandemic. And we definitely need to encourage targeted policies and programs for these special groups. Next slide. And thank you so much for listening to us. But last not the least, I would like to take this opportunity to thank our funders and partners and supporters, the University of Ottawa, Social Science and Humanities Research Council, Statistics Canada, and Policy Horizons Canada. Thank you very much.
Thanks so much, Arunika, and to the whole team. That was a terrific summary, and we can jump into the Q&A session, but you've been very efficient with your time in terms of presenting. So I just wonder if there's any further comments that any of you would like to add in terms of anything that you would add to the current presentation. I can start with you, Roland.
Thank you, Susan. Well, first, I would like to thank all my colleagues who presented. You know, nothing really specific to, you know, special to art to what has been said here. But I'm seeing questions in the chat box. Would you like us to jump to questions or?
We can, yes, that would be great. Yeah, we can start there, that's fine. So first question from Christine, who's entered two here. So interesting, thank you. You talked about the female excess in symptom reporting and male reluctance in testing. Is it time for a campaign targeting men to encourage them to seek help and get tested? Would any of you like to take that question?
Well, I think we should be encouraging you know, everyone to observe or to follow, you know, social distancing measures and testing and all those measures that prevent the spread of COVID-19. Yes, it appears that men were less likely to get tested or even to follow social distancing measures, and it seems that, you know, men here are a special group that perhaps should be targeted in campaigns and all kinds of interventions. But we should first try to understand why, you know, men are less reluctant to follow those measures. Perhaps my colleagues will have something to say.
So yeah, if I can quickly add to what Roland just mentioned, I mean, I totally agree with what you suggested, and I would say this result basically they clearly suggest that we must have our particular attention must be paid to symptoms and testing levels among males. But as Roland mentioned, that doesn't mean that we should not also encourage other groups. And one thing also that is important to mention here is that this result should also be interpreted with some caution, because due to some of the limitation that we might have in the sample, or the fact that self-reported symptoms are by their nature subject to limitations and misclassification. So that's why we should probably, there's need to better understand why we observe this association with further analysis. And I also think that by doing the analysis with the other ones of the survey that we are now collecting, we might be able to provide and show whether that we observe a persistence in the association over time, but also provide maybe more details on why we observe this association. Yeah, so that's my 1 cent to the answer.
Thank you, Christelle. Anybody else on the panel would like to offer anything on that question?
Yes, and probably maybe in terms of testing and in terms of mitigation measures being lower among males, theoretically, we may look at the issue of risk perception. And I think that the issue of risk perception may contribute so much to why males and are less likely to test or observe these social distancing or mitigation measures, because in a lot of health conditions, literature shows that men usually have low perception when it comes to risk. So when the person thinks that I am not really at risk of getting the infection, then the issue of testing or even social distancing or maybe practicing other mitigation measures at the workplace or even wearing a face mask may be less likely among those people. And to some extent, we may attribute these disparities in terms of the testing and the mitigation measures, which is lower among men, to their level of risk perception, which may have contributed to this results. Thank you.
Thank you, Bright.
And
yes.
If I can add something, Susan?
Go ahead, yes.
Yes, and following what Bright has just said about, perceiving risk, yes, it is true that, men do not usually perceive risk as women do in general. But, I should also add that they only have a wrong sense of security, basically, because when we look at the data, in terms of self-reporting symptoms, self-reporting symptoms are more prevalent among men than women in general. So they were more likely to report COVID-19 symptoms, and that seems to imply that that intervention campaigns, should bring the awareness of men to the fact that they are truly vulnerable, to COVID-19.
Thank you. So second question from Christine. Would you be able to speculate, Ms. Agarwal, on why you think men were found to self-report depression more than women, and women were found to self-report anxiety more than men, which she found surprising because the literature always emphasizes how depression is more common in women. So comments on that?
Yeah, sure. Thank you, Christine, for a wonderful question. So I would agree that usually what in the literature, females have been found to be suffering more from depression than men. And in our sample also, the difference is not huge. It's like 25% of female and 26% of male, but still, and most of this prevalence is driven by younger age groups, so 18 to 44. And this age group is usually overlooked when we like the mental health problems among males. So males are usually like overlooked, and they, as Bright and Roland also pointed out, their perception of risk is also low, and they also don't open up about. So there is this taboo also about depression, so they don't open up so often as maybe as females. So that could be some of the reasons of reporting higher depression rate in an online survey and not to an individual in a face-to-face interview. Does that answer your question, Christine?
She answered yes, thank you. That's great. Thank you, Arunika. Dr. Mary Bartram from the Mental Health Commission Canada. I noticed the difference between mental health impacts for people 65 to 84 and those 85 plus. Were those over 85 living at home or in institutional settings?
That's a very good question. And unfortunately, we do not collect this information where the respondent is living, whether it's a household or it's a community or it's an institution. Is that correct, Roland?
Yes, it is. We didn't collect that information, unfortunately.
But that's a very good point. And I think we should definitely add this question in the next round just to check. I agree, like a higher percentage of 85 plus population lives in institutions. And that is one of the groups that has been ignored and also suffered the most. So we should definitely add this question in the next round.
And I'll just tag on to that. Are there any other mitigating factors that you might consider just for why that age group 65 to 84 was lower than the others in the findings?
So we have not dig deeper into this, but that is something really important, and we will be working on that to find out what are basically the determinants of higher prevalence among younger age group, but lower among the older age groups. But if you still compare it with pre-pandemic times, the prevalence across all age group is higher than what we observed in pre-pandemic in 2019. Mm-hmm. So all great age groups have been affected, but unfortunately, the youngest age group have been affected the worst.
Just wondered if that group is doing anything particularly well in terms of coping, but hard to tell. Thank you. From Tara Moriarty, these are incredibly useful data. Thank you so much. I have a question about high income and reduced adherence to social distancing measures. Are high income men a particularly prominent group for this issue? Do you notice any geographical location where this is more common? Roland?
Yes, just as you are talking, Susan, I'm looking at the results, and yeah, just give me 1 minute. Well, our finding here shows that that income is not really associated with social distancing at work. But what we found, we really do not find any association between income and social distancing at work, but we find association between income and other COVID-19 related outcomes such as mental health. So here, I do not know, we didn't conduct the analysis, but this is something that we can do with our data. Perhaps the effect of income on social distancing might vary from, let's say, one province to another, or from, one ethnic group to another. But this is something that we don't have any evidence for at the time being, but something that we can certainly investigate. I don't know if that answers your question.
Yeah, we could ask Tara to refine the question or follow up if there's anything further there. She's asked a second question here. Similarly, for reduced social distancing adherence and lower vaccine uptake or confidence among racialized people, are there geographical regions where these trends are more prominent?
Well, again, we did not conduct analysis for each province, for instance. Okay, I mean, but this is definitely something that we can do because we have, quite a good sample for certain provinces like, Ontario, Quebec, and even British Columbia. So we could basically replicate the analysis that we did here for the whole country, for each province. And after that, we'll be able to answer the question that that Tara has asked. But these questions are very important.
Good, thank you. We could unmute Tara as she's requested, just to clarify or follow up her question. I don't know if that's possible.
Can I add to that, to what Roland said just now?
Mm-hmm.
So I guess, I don't know if it is correct, but on slide 25, where we are showing determinants of personal preventive measures, we did show that the higher income groups have lower odds of reporting preventive measures. And that could be because lower income groups are mostly employed in essential services and services which have higher exposure or higher risk than the higher income groups, which were mostly working from home and actually do not need to be there in the public spaces. And so maybe social distancing was not applicable to them, instead of saying that they were not following social distancing.
Yeah, I understand that. The reason I'm asking is I've been really following closely the regions in Canada where vaccine uptake is lowest, especially among people 50 and older, 40 or 50 and older. And of course, a lot of these regions are rural, and you've got specific regions in Alberta and Saskatchewan and BC and Ontario. But one of the things I noticed, I was, looking at the Stats Can demographic profile for the regions with the lowest vaccine uptake among older people. And one of the things I'd noticed was that there was a higher proportion of high income men in these regions. So income wasn't higher than the national average for women, but it was for men. And there were also much higher rates of secondary education or less, or employment in the trades, which I think as a gut check is maybe consistent with some of what the images are that we have of who may be anti-vaccine. Or anyway, I was just curious how much geographical detail you had, because we're trying to target interventions, one-on-one and support outreach to not only to regions, but then particularly high-risk demographics. And in some of these rural regions, it's identifying who to reach. And yeah, anyway, I was just really curious, right? It's really interesting to see what your data are showing. And the regional stuff would be really interesting. And Quebec seems to be much better for vaccine uptake across the board, and in all Quebec and Atlantic Canada compared to anything west of Quebec. Among older people anyway, among people 40 and older.
Okay.
Good, thanks, Tara.
Thank you.
Just
Thank you so much.
Regarding Tara's question on urban-rural, we do not collect that information explicitly, but we do have like postal codes of your respondents, and this can be done at the later stage. Just to by postal codes, we can disaggregate them by urban and rural residents.
That's great. Thanks, Arunika. Okay. Thanks, everyone. So we'll move on to the next question. So did you discover which factors contributed to the men in BC being less likely to report than men in Quebec? Any explanation for the geographic variation on that one?
I think that's, if I can answer quickly on this, I think that is something that we should do, also related to the question we asked about the geographical analysis. I think this is something we will probably be able to analyze deeply to see what could be the main factors that explain this difference across the province. But for now, we have not done such analysis yet, but definitely we'll try to better understand what are the main factors by disaggregating by province and see what is left in the association, basically. So thank you.
Great, thank you. I'm wondering if I might ask a question just about what you will do with these results in terms of the knowledge translation and implications for policy, practice, public messaging, public health advice. Just curious what your next steps are in terms of the translation and knowledge products.
Susan, this is a very important question. I should mention that we've been working with several partners. Policy Horizon Canada is one of our partners, and they are very interested in how networks affect the spread of COVID-19 and how people form networks or follow social distancing measures during a pandemic like COVID-19. So we've been working closely with them to generate results and also to design surveys. Actually, the third round of our survey benefited from their inputs. I should also mention that this study is an international study because we are conducting similar studies in Guinea, in Africa, and we, depending on whether we get funding, we hope to extend the study to Kenya. In Kenya, for instance, we have partners that in both countries, we have partners. We are working with partners from the African Population and Health Research Center in Nairobi to try to understand how understand how different socioeconomic and demographic factors affect, compliance with preventative measures related to social-19 and to COVID-19, and to also try to understand what are those factors that affect vaccine uptake in those countries. There was in the chat box, there was a question about vaccine. I should mention that in Canada, we also collected data on vaccine, especially in the third round of the survey, the third wave. And then we'll be able to analyze, vaccine hesitancy among these different socioeconomic groups in Canada. So in terms of translating knowledge into policy, again, we are working with many partners.
That's terrific. Anybody else on the panel want to respond to that? That's great, but there are some clear implications for public health messaging and intervention here. So thank you for this. A question here from Kim Knowles. These analyses focus on the early part of the pandemic. Can you give us a sense of whether these patterns persist across subsequent waves of testing?
Well, right now we haven't analyzed the other waves of the survey, but after the analysis, we'll be able to give an accurate answer to that question. But what I can say right now, based on my own observation, is that when you look at factors like ethnicity, age, and based on my readings of other studies, I think that what we have found in the first wave of the survey is likely to have persisted, during the pandemic. We'll still see we know, for instance, that visible minorities have been highly affected by the pandemic. We also know that low-income groups have been affected, basically because of the kind of jobs that that individuals in these groups do, because of the kind of jobs that they have. So I won't be surprised to see similar patterns in the second and third waves of our survey.
That's great. And actually the next question is related to that from Mike Warren. Did you say you collected data over other time periods? Is that correct? And if so, sorry, my screen just jumped there. Did you find any changes? So maybe you could just specify which data, or sort of which time periods you are collecting data.
So yes, we are doing, we collected additional data in the two other waves. But for the moment, as Roland mentioned, unfortunately, we have not yet done several analyses, and we cannot clearly see whether the pattern persists or not. So just to give you an idea of what we have done with the data collection. So the second wave was launched between December 2020 and June 2021. And the third wave cover, which is still implemented, is started in June 2021. So basically, the goal, the next step is to actually look at all these patterns, see the persistence within the two other waves, and also try, as with the good suggestion, to look at the geographical differences. We also try to look at these geographical differences, and we'll be, I think we'll be able to provide detailed analysis, or to provide more information on what is the persistent pattern that we observe, and also provide some information on a vaccine, because as Roland mentioned, in the last wave, we are also collecting data on vaccine. So yes, that's what I can see on the surveys.
So stay tuned in a sense, and I think that's probably the
Absolutely.
answer to the next question, which is, have you noticed sort of a large difference in compliance with preventive public health measures? So that those kinds of trends will be really helpful to see as you progress with your study. Yeah, thank you. Thank you. Just a comment from Tara there. She has to run, but thanks so much. And she would like to stay involved and learn from you. So that's terrific. And Kim Knowles has also asked and said thanks for your previous answer. And she's particularly curious about the gender findings. It will be interesting to see how things go. So any other comments on the gender findings there? No. Just wait and see. That's great. And Mike also says thanks. Look forward to hearing about your findings in other time periods. That's terrific. So I'm just curious a little bit about, you're an international team. So maybe you could just talk a little bit about the international context for your study and other work that's going on with your team.
Yes, Susan. As I mentioned earlier, we've been working with partners in Guinea. We are conducting a similar survey in Guinea, and we hope to conduct the same survey in Kenya. So, as you know that the members of our team are from like everywhere. One of our presenters today, Bright, is from Australia. And our goal here is to try to understand the situation of COVID-19 and the predictors of COVID-19 related outcomes, in representative context. This is because we are aware of the fact that a factor like education or income might not have the same effect in Canada as, let's say, in Kenya or in Ghana, for instance, okay? So if we are hoping to get the kind of results that can be translated into policies, then we have to understand each specific context. And even within a country like Canada, income might not have the same effect for men and women. Income might not have the same effect for minorities and other groups. So we really have to conduct context-specific analysis in order to highlight the determinants of COVID-19 outcomes, in all of those contexts, to be able to inspire policymakers. And that's why we have an international team. That's why we are trying to conduct surveys, wherever we can with the funding that we have.
Very good. Thank you. I just posted a question there. Are there any final questions from anyone on any aspect of these studies or future studies?
There is a question in the chat box.
Oh, sorry.
From CRA.
I just missed that. Countries have implemented different approaches to prevent the spread of COVID-19, such as partial lockdown, complete lockdown, etc. Do you think these differing approaches have had implications on their population's mental health?
Hi, Chiara. Yes, definitely. So we have seen, so I have been involved in other surveys as well in the US and India. And I can tell you about India for sure that when the COVID-19 lockdown was implemented in India, it was the strictest lockdown across the globe. And we have been doing similar longitudinal surveys in India too. And we found that just after the first lockdown, the anxiety and depression levels just shoot up, and then they were dropped down subsequently, like after a few months. So definitely these policies have impact on the mental health of the people, because people haven't seen something like this in their life. This is a once in lifetime event. So and this is something which we will be considering in our future analysis, the effect of policies at the national and at the subnational level in Canada as well.
Thank you. It seems as though that's the end of the questions now, and I just want to say thank you to all of you for your presentations and this wonderful work. There'll be several people on this, and I'm sure around the world, watching for the future results from all of your studies and your work. So thank you very much. I just would like to say also thanks to the CanCOVID home team for their support in co-hosting this today with the University of Ottawa and your team. So thanks so much, everyone.
Thank you, Suzanne.
Thank you.
Thank you. Thank you, everyone.
Yeah.
Thank you.
Enjoy the weekend. Bye-bye.
We would like to thank our speakers and members of our network for their continued support and participation in Canada's pandemic response. If you are interested in learning more about CanCOVID or joining our Pan-Canadian COVID-19 Research Network, please visit our website at www.cancovid.ca.